And, that's just how it has been set up. We do know also that hospitals are owed money. They're entities, facilities that have been owed money for a very long period of time. How does this play out in terms of how patients are treated, or in this case, not treated, right? So if I present myself to a facility today that is owed money in the same health system by the government, the likelihood of them treating me as a patient then is reduced, because they say, hang on a minute, you're in this system that already owes us money, and for whatever reasons we've closed the taps. These are real life situations. It's not a makeup or Alice in Wonderland. They say we will not offer services because here is this money it's not been paid. Now, in this case, myself as the person who has shown up as a patient, I don't know what's happening between government and the facility. That's your business. So here I am, and I've paid my premium, but I can't get treated. What are you advising this individual to do? Go to another facility, number one? Or are you saying, come back until we sort out our issues? What's happening with that particular issue?
No, granted, and it's not arguable, that NHIF, the old NHIF, owed facilities money. And it's not little money. Mm-hmm. It's quite some money. Most of them... Some of the claims are, of course, as you'd expect, are questionable, and Kenyans being Kenyans. In fact, part of the reason why we came up with this system is to stop that abuse that would see people, having all sort of, fictitious claims on NHIF, and thereby diverting the resources that ought to go to all Kenyans. And that's one of the things to celebrate about the new system. Now, what did we do? What is the problem, first of all? The problem is that we would want to have all the money that are required to run this program. Right now, as we speak, only the three of you and 2.7 million other Kenyans are paying for 45 million Kenyans. I mean, it's a huge...
repeat those numbers again, please.
2.7 million people, pay-three people, are the ones paying for 45 million, for 54 million Kenyans.
Really?
Yeah.
There are some people who are not pay-slipped who are paying their premium.
Half a million of them.
So
half a million
are
out
they
of
additional?
16
Are they
million.
Additional to this 2.7
The
million?
2.7 million are the pay-slip people.
So then what we're actually looking at, if you say 500,000 people, give or take, so we're looking at 3.2 million people.
Yeah, carrying the burden of everybody else.
Okay.
Yeah.
So those who are not employed in formal employment, who are paying premiums currently towards shift, are 500,000.
Yes. And that's why, because we said, because Kenyans are struggling with this new system, to understand it, to register, to do many things, deliberately we went easy on enforcing that everybody must pay. And that time is running out, because for how long can the payslip people carry the burden of everybody? Remember, they are doing the same for housing.
The money will run out.
Yeah, the money will run out, yeah. So we have really shown the financing, yeah. And it's what you're going to see us doing going forward. Because that's why we came up with this issue called means testing. Whereby, because you are already means tested by your salary. But that person there, who sometimes they have got more money than even the salaried people, yeah? That everybody has to go to do this means testing. Because what people forget about SHA, SHA is nothing new, but the old Harambee system, where I've got Harambee. So Mr. City Muga is going to be invited for a Harambee only by the people of his village, because they know him. But now SHA is a national Harambee for everyone. For people you know and people who don't know. For people of your village and people of the farthest corner of this country. And in this Harambee, right now, the people who are contributing in this Harambee are only 2.7 million people. Before SHA, I was contributing 1,700. Today, I'm charged 27,000 shillings, per month. But I'm not complaining. Why? Because for me, it's a savings.
Okay.
Because if I compare with how much I was contributing to Harambees, it's a problem. Now, what I want is that I don't want everybody to contribute 27,000. But even if you bring 500...
Even if you wanted it, it's not 400 possible, because they don't...
Yeah, exactly. Exactly. That's why you're saying to everyone according to their means.
Yes.
To everyone according to their blessings.
Yeah.
And that's exactly where we need to go, so that all of us can be able to move together in that journey.
I want to go back. Sorry.
I'm coming back. So I want to give you the problem, first of all. So with the money that we're getting, and by the way, the income with this new formula, this Harambe, even without the other people paying, compared to the old NHIF, the collections are already up by 400%.
Since when?
Since 1st of October.
Okay.
Compared to the, month on month, how much we are collecting every month now, compared to how much we are collecting before. Okay.
Just sorry, I need you to break that down. I think it's important that we do so that we're not just throwing numbers out there, Waziri.
Yeah.
So we are saying that with the system that was in place, it was more than 10, but let's just say for 10 years.
Yeah.
So we're saying that with NHIF in 10 years and what was being collected, from the 1st of October, when we saw the shift to the new system, we saw an increase of 400%.
Of, let's say, we were in the region of more than double. Let me say that way.
Okay.
Just shy of more than double. What NHIF was collecting every month compared to what SHA is collecting every month.
Was that because more people were contributing, or was that because the amount of money, or was it because of the amount of money that people then had to contribute by virtue of the fact of the increment made a difference?
Absolutely, because it's Harambe.
Yeah.
This Harambe now starts saying, hey, how can Moses Kuria contribute the same amount to this Harambe with the city Muga?
So it's possible that the same people who were contributing NHIF for 10 years are the same people who are contributing to SHA, but the money increased because the government said because you need to have more money.
Yeah, because of the means. And now you can imagine once we do this means testing even for the other guys and get everybody contributing in this national Harambe, you can imagine the system will be liquid. And even before we move to those people who are not contributing, by this double amount that we received from SHA compared to NHIF, we came up with something called RIFO. It's an accounting terminology. Last in, first out. We said, yes, I know I owe this hospital money. And I know that all debts of NHIF has automatically transitioned into SHA, okay? But for what you are claiming under the new system, I will pay on the spot, okay? So you clean up first what's happening today, then you start working backwards to the old debts. That's why today, even if we owe hospitals money, even if we are looking for the money to be able to settle the debts, even if we are trying to do the verification of those debts to separate the genuine ones from the fictitious ones, the cases of hospitals turning away patients have become almost negligible, less and less. Why? Because we say, look, search me. What you claimed yesterday or last month or whatever you've claimed since October, I have paid you. Meaning that I've demonstrated goodwill. Yeah, I've demonstrated goodwill that I have nothing to hide. And I'm telling you, yes, I know. I still acknowledge, I still owe you the debts of last year. But since I'm not accumulating new debts, so even this problem, again, go and do your survey out there. We have got less and less and less complaints about people being turned away because people have seen demonstrable confidence, by hospitals to say that even if I am owed money that came from NHIF, at least on the new money, I'm able to, to get sorted. And that's why you're saying, because all the claims are coming now through the system automatically, because the claims are coming through the system, also the settlement is coming through the system. That's number one. Public hospitals and private hospitals. Now let's go back to public hospitals.
Yes.
For public hospitals, according to the patients who are visiting that particular facility, the new system, the new law came up with something called FIF, Facilities Improvement Fund. That money is given to a facility to improve themselves. Okay? And they retain that money at facility level. Something that was not happening at NHIF. And that money can be audited. It is automated. It is trackable. What we are doing now is that we're saying, because first of all, we have got two things that we are encouraging counties to do, especially county government. One is to say that zero takeout. It's a principle of zero takeout. That all the money generated from a particular facility are retained in that facility. Don't take it away.
For development.
For development of that facility.
Because that was what I was going to ask you.
Absolutely.
I think this is one of the things that is vital here.
Yeah.
That one of the main issues we had is that, when we looked at the system, is that your lower level medical facilities, 2, 3, 4, were being more or less ignored
Absolutely.
by people because they wanted to go to your higher level facilities for a headache, a common
Absolutely.
cold, things like this. At the same time, your very serious interventions that needed to take place were slowed down because of lack of infrastructure. Right?
Absolutely.
If we're looking at Kenyatta National Hospital now, just look at the cancer ward, for example. If you want to get a scan, you want to get an MRI, and you're a cancer patient, the waiting line is ridiculous. So what happens is, what we're asking now is that people who travel, and this is the thing, people travel from Murang'a, come to Nairobi, people travel from Mombasa, come to Nairobi, people travel from all over the place, come to Nairobi, and then they put on a waiting list for 3 months to be able to get a head scan, for a medical intervention. Now, the question is here, whether there's a new system in place or not, the physical infrastructure in the facility still remains the same. So what is the transition then between the new system and ensuring that, okay, fine, this new system, swanky system in place, we can pay our premiums, get in line and do everything, but what is to guarantee that I'll walk into the facility and the ground really is actually ready to receive?
I like this question because what you've just described is exactly what was the vision of SHA. And you mentioned level 2, 3, 4, but you actually left out one level called level 0. Level 0 is a community health promoter.
Yes.
They are actually part of the infrastructure right now. They are part of the service delivery mechanism that for the last 2 years, they have visited 8 million homes. And they have referred people with diseases like hypertension, diabetes, etc., 350,000 of them into facilities. And now with the new system, your CHP, the CHP in my village is going to go to my mother and take the triage at home.
Yeah.
And from their gadgets, which you've given them gadgets, all the 110,000 CHPs, they will be able to refer my mother to the next level 2 hospital. And they will find level 2 hospital in the system waiting. Oh, are you Moses Kuria's mother? We have been waiting for you because we were told you are coming by CHP on the system, it's showing.
Yes.
And then from the level 2, some cases need to be referred to level 3. That's happening automatically now on the system. You can be able to track. And actually, the case of this morning in KNH is because it was auto-referred from a system, from a level 2 hospital, from a level 3 hospital. Before, there was no audit trail. You cannot tell whose word it is. You cannot, and therefore, people only believed that you can only get some good service from Kenyatta. That's why you find the higher levels, overwhelmed, because even kids, that's what we are calling the primary health care. It's supposed to be primary.
You know the other reason why they go?
Yeah.
Because when they go to the level 2, 3, 4, sometimes, and a lot of complaints came in that you can get a referral to a level 2, but that you go there and the infrastructure doesn't exist.
Absolutely.
Radiology, but there's no radiologist.
Hence why now we have this facility improvement fund, whereby every level 2 hospital get money for itself. A level 3, a level 4. I can tell you, this hospital in a place called Kitimikai, how much money did it get? For how many patients? What did they do with the money? Let me give you an example. The governor of Mombasa has issued an executive order, governor of Mombasa, one of the most switched on governors in terms of healthcare. He said that he's given 3 very serious rulings, executive orders. One, if money comes to a facility, money does not leave the facility. That's rule number 1. Executive order number 2, 60% of that money will go towards buying medicines. And that has been automated in the system. Yeah? So we are going to have a lot of this issue of going to the hospital and you find that there's no medicine. Someone has to answer because we can see that the money was deducted and money has gone to the medicine. The number 3 thing he has said, this year, starting from the 1st of January, he is not renewing the licenses of pharmacies that are operating outside hospitals. Because you know very well what those pharmacies were there for. You go to the hospital, there's no medicine, but you are told out there, in that particular one, you can be able to get the facility.
Is that really fair?
Yeah?
Is it really fair?
It is fair.
Because you're assuming that because a pharmacy is near a hospital, the only clients would come to those facilities are probably referrals from the
Near the
hospital.
hospital.
What if the pharmacies are near a hospital and the hospital is near residential areas?
You know,
And as well as the city talks about that. I mean, our spot check that we did last week in Mombasa, since you're talking about Mombasa, shows that patients go to hospitals and they are asked to go back. They're denied services because they are registered under SHA. As much as we want to heap praise on Mombasa, there are teething problems in that same county as well that need to be addressed.
and maybe not. That's why I said, give me the ID number. Because I can go to the system. That's a whole wonderful thing of having a system that is auditable. Because if you tell me this number, I'll tell you, yes, this maybe you are helping me. Because people refer these cases and they end up helping us. But I'll tell you something. The other wonderful thing about these facilities of level 2, level 3, and level 4 is that they are not the only people under SHA. The public hospitals. You get treated in the private hospitals in exactly the same way you'll be treated in the public hospitals. I mean, SHA does not discriminate. And that's the other wonderful thing. And so, therefore, governors have smelled the coffee. They know if you don't improve these facilities, all the patients will be going to the private facilities. Because as a patient, you don't lose anything. Yeah? You choose to go to a Kibanda or Serena Hotel, and the price is the same, the treatment is the same. So this internal competition, this sibling competition between private facilities and public facilities is going to see, a mutual improvement. I have seen private hospitals also, they are now, waking up, and they really want to be part of this success story because they know the government facilities are getting this facilities improvement fund.
Yeah.
The government hospitals know the patient can go to the private hospitals. Ultimately, the system will be self-correcting.
The picture you paint is the picture one wants to see with regards to our healthcare system. In fact, when you're talking about public facilities, you talk about government facilities, that is where the vast majority of people would go to, because whatever you say, it's always been found to be affordable. There's something you mentioned which I don't quite understand, literally. The Facility Improvement Fund. If SHA is working, the patients who go there do not need to fork out any money.
Precisely.
Now, the money that then the health facilities would make, where would that come from?
It's come from you.
How? I have SHA.
You've paid a premium.
I paid my premium. All I need to do is produce my card or show my
Your
ID.
Oh, okay, let me say it this way.
Yes.
Public hospitals.
Yes. It's public
Let me make a
hospital.
statement.
Yes.
Level 2,
Yes.
level 3,
Yes.
nobody, level 4, nobody goes to those hospitals and is asked to pay a penny as long as you're a SHA member.
Yes.
That's a statement of fact.
Okay.
For any disease,
Yes.
okay? Subject to the tariff that is put there.
Yes.
I have a problem with this tariff sometimes also, because if you look at some of the benefits, for example, on the ICU and the HDU, and the few complaints now you are getting on the ICU and the HDU, if you are in Coast General Hospital, in ICU, you get covered for 3,940 shillings every day. Sometimes the cost is higher than that. Yeah, I would want to see more benefits going to the ICU, what we call the critical care. The ICU and the HDU.
Yeah.
I would want to see more money. Once we get these other 16 million people from the informal sector to come and help you, the payslip people, and we get more money, we are now forming a committee to review the benefits. The benefits are going to be reviewed commensurate with the availability of resources. That is why we want now to start this huge campaign of people to start to do the means testing and start paying for this, so that we get more money. Because if I add even by 50% the money available, maybe I'll be able to afford, more benefits to the people in the ICU and the HDU. So I would say, and also, of course, because of our fiscal situation, we are not getting money from the exchequer for the primary health care area as much as I would want to see. I would want Kenyans to continue paying taxes so that we can be able to fund the primary health care as well. So what I'm saying is that we have got nothing to be pretentious about. Where there are issues, there are issues. And I think what we owe to Kenyans as a responsible government is where there are gaps. For example, I'm telling you, we have got obvious gaps on the ICU and the HDU. We are not covering the benefit as much as we want covered. I would want more money to go to cancer patients. I would want more money to go to, all the other chronic, cases. I would want the emergency and chronic care fund, ECCF, to be funded because, health is a priority. And it is one of the Article 43 rights in our Constitution. So I want to see more budget support. And I'm talking to our members of Parliament in terms of appropriating more money for our ECCF within this, even the supplementary budget and the budget. I would want to see, more money going into our commodities. What I'm saying is that as we are fixing systems, we're also going to fix the monies, and we are going to fix the monies from both ways. We are going to fix the monies by people in the informal sector also agreeing to pay to help the people in the formal sector. And I would want to see also the Parliament appropriate more money, and please talk to your members of Parliament.
For it to come here.
To appropriate more money.
Yeah, Waziri, you'll be with us here for another hour. And an opportunity for people to ask you ask you questions directly, because you said, let's deal with those bugs if we can. So Waziri will be with us here after 8 o'clock. Let's take a break now and look at what's happening with the news, and then we'll come back after this.
So I can take a health break.